Hi and welcome to my podcast on adhesive capsulitis, When Does the Pain End? A research proposal by Alex George. So adhesive capsulitis, or frozen shoulder, is the thickening and contraction of the glenohumeral joint capsule and formation of adhesions causing pain and loss of movement. Here is a clip showing a little bit about the condition. So frozen shoulder is an extremely painful condition in which the shoulder is completely or partially unmovable. The capsule around the shoulder joint, which is normally very flexible and elastic, becomes inflamed, swollen and contracted. Here we can see the anatomy. The normal condition of the capsule turning into a thickened capsule as you see in frozen shoulder. You get inflammatory synovositis, and middle glenohumeral ligament also becomes inflamed. So the causes, there's three main causes. So spontaneous, where there's no known cause. Rotator cuff injury, such as in trauma, for example, when my mum fell down the stairs head first and decided to break her humerus, and this caused the rotator cuff injury and resultant frozen shoulder. And also in conditions causing immobility, for example, a stroke or plaster immobilization. Some epidemiology. So it commonly affects ages between 40 and 65, and the average age is between 50 and 55 years. It affects around 3% of the adult population. It's more common in women and common in those in diabetes. There is also an association with thyroid disease. So symptoms, the main two symptoms are pain and reduction in range of movement. Just some information regarding pain. So it usually affects the non-dominant shoulder, although it can occur in either shoulder. There's usually a gradual onset of severe pain in the shoulder, which is associated with stiffness and a resultant reduced range of movement. There seems to be a reduction in both active and passive ranges of movement. Patients often complain of an inability to sleep on the affected side. There's often a restriction of activities including driving and dressing, particularly in activities that need external rotation. In terms of pain, there's three phases that seem to be classified. So phase 1 is severe generalized pain associated with stiffness. Daily activities are limited, for example putting on your jacket. This tends to last up to 9 months. So phase 2, pain usually gradually subsides but the shoulder is stiff. Movement becomes more limited, and external rotation is usually very limited. This phase lasts between 4 and 12 months. Phase 3, shoulder becomes less stiff. There is an increase in range of movement, and this usually lasts around 1, 2, 3 years. The average length of time appears to be around 2 years. So, in terms of diagnosis, this is done clinically. The whole shoulder joint may be tender to palpation, and the diagnostic test is usually an inability to do passive external rotation. The aim is to treat early. Ideally, you want to prevent an episode of capsulitis becoming adhesive capsulitis. A holistic approach to treatment should be used, considering psychological and psychosocial factors. The first stage of analgesia is paracetamol, and secondary use of a non-steroidal anti-inflammatory such as ibuprofen. Provided there are no contraindications, these can be used. Also, some patients say that a TENS machine can be useful. Activity should be encouraged early. Patients should be provided with written information, leaflets on the shoulder pain so they know what to expect and how to deal with it. Physiotherapy combined with steroid injection has been shown to have early significant improvements with respect to improving shoulder range and also pain. Injections with corticosteroids may reduce pain and duration of symptoms in early stages. However, in the later stages, it appears they become less effective. There is no benefit of ultrasound-guided steroid injection according to studies. Oral steroids don't seem to provide any benefit over injected corticosteroids. Some surgeons then perform manipulation under anaesthetic and arthroplastic capsular release if the adhesions in conservative treatment fails. So in terms of prognosis, symptoms tend to persist up to around 3 years. However, 90% of patients have spontaneous recover from spontaneous adhesive capsulitis at around 2 years. There should be consideration for referral to secondary care if pain and significant disability are present for greater than 6 months, despite appropriate conservative management. Relapse in the same shoulder is fairly uncommon. So what is already known? So the natural history of idiopathic frozen shoulder, a 2 to 27 year follow-up study, was conducted recently. This is a retrospective study of 82 patients followed for between 2 and 27 years, depending on how long they had the condition. There were 3 groups. So there was those observed with who were observed as treatment. There were some who had non-operative treatment, and some who had manipulation under general anaesthesia. Between all groups, the average duration of the disease was 15 months, until it was said they were pain-free and had reasonable movement. In terms of some stats, 51% of patients in the untreated group, 44% in the non-operative group, and 30% in the manipulation group were totally pain-free at rest, during night and with exertion. Pain at rest was at less than 3 on the VAS score in 94% of patients in the untreated group, 91% in the non-operative group, and 90% in the manipulation group. However, a note is that there are few follow-up studies into the actual pain, and doesn't seem to be a lot of actual focus on patients' experience of pain, and this is where my interest in the research focuses on the patient's experience of pain. So this brings me on to my research proposal. So how long from the first consultation onwards does it take for patients with adhesive capsulitis to become pain-free? So I'd like to look at, as I say, the patient's experience of pain and use a quantitative scale, so the VAS score 1 to 10, but also incorporate other questions about what the type of pain, severity, location, how it restricts them, how they actually feel. Then patient's pain would be assessed in every consultation using a questionnaire. This allows a patient to fill out a numerical score themselves without having to talk to the doctor, might not, and then there's less likely to be bias upon their answers, if you like. How my research proposal will benefit patient care. So research into the average length of time taken for a patient to be totally free of pain. It provides data for comparison of different forms of treatment. It's cost effective and can be based on patients' experience of pain, and I believe it will improve patient care. So is it achievable? So the strengths of the idea is that it provides useful measurable data, is time friendly, and makes patients feel valued. Limitations: people have different perceptions of pain. So to one person who might have gone through childbirth, for example, their threshold of pain would be far higher than someone who would never have ever experienced any serious pain. So this might skew the data slightly. They may not have consultations close to the time the pain ends, because my focus is actually on when does their pain end, from start to finish, how long does their pain last, and the accuracy might be out a little bit if this, for example, an appointment isn't for another month or so. Healthcare professionals may forget to take the score, so to give out the questionnaires and record the data. Thank you for listening, and I hope my research proposal is okay. Here are the references.